I'm Mel Edwards, Senior Vice President and Executive Director for the Greater Houston Gulf Coast American Heart Association. Thank you once again to all of our speakers and to you, our attendees, for being with us today. Cardiovascular disease is the #1 killer of women, claiming the lives of 1 in 3 women. Cardiovascular disease is also the #1 killer of new moms, as pregnancy-related deaths in the U.S. are rising at an alarming rate. Between 1987 and 2015, pregnancy-related deaths rose by 140%. It's important for women to take charge of their heart health and encourage their mothers, sisters, and friends to do the same while expecting a new one. Pregnancy is a stress test for a woman's health for the rest of her life. This is why access to health care, good primary care, awareness and education after the birth of a child is essential to the mother's survival. I'm pleased to introduce Catrice White, board member of the American Heart Association in Montgomery County and Vice President of Texas Children's Hospital, The Woodlands, to provide this program's opening remarks. Catrice has a 20-year career history with Texas Children's in various capacities, including building and executing the vision of providing world-class pediatric care in the West and North regions. In her time as an executive leader with Texas Children, she has developed business strategies and financial plans, established recruitment and hiring practices, and has had oversight of hospital and ambulatory operations. As a recipient of the Mark A. Wallace Catalyst Prestigious Leadership Award, Catrice is a well-respected healthcare leader, and we're honored to have her do opening remarks today. Welcome, Catrice. I'm Mel Edwards.
Thank you, Mel. What is more important than getting off to a great start in life? A child deserves a healthy family and a healthy mother, and yet maternal health in Texas is fraught with challenges before and after birth of a child. Addressing maternal health is an important priority for Texas Children's network of care in terms of community health. According to a 2016 study published in the Medical Journal of Obstetrics and Gynecology, maternal mortality in the U.S. skyrocketed by nearly 30% between 2000 and 2015. And Texas maternal mortality rates doubled between 2010 and 2012. This is a public health crisis that faces the state of Texas. According to the Maternal Mortality and Morbidity Task Force, Texas women are the population most at risk of dying after giving birth in the United States. Notwithstanding discrepancies between the Texas Department of State Health Services data and the CDC data, as well as misreporting on death certificates, researchers argue that Texas maternal mortality rate climbed to roughly 35 deaths per 100,000 live births since 2018. This is an unacceptable reality in Texas, and those of us in healthcare can work collectively towards improvements. To start this discussion today, I want to introduce Heidi McPherson, our moderator. Heidi comes to us today to moderate our panel discussion with over 15 years of professional experience in public health and community development, serving in local, national, and international roles. She is passionate about catalyzing collective capacity for improved population health outcomes. Heidi served for 5 years on the American Heart Association's Community Impact Team in Houston. During her time with the American Heart Association, she developed a statewide strategy to improve hypertension control across patient populations, and she co-led the city's largest coalition for health, the Health Equity Collective. In this role, that brought her current role at the UT Health School of Public Health and the Michael and Susan Dale Center for Healthy Living. Welcome, Heidi.
Thank you so much, Catrice, and thank you to the AHA for hosting this important conversation I'm really excited to be a part of bringing the science and the recommendations and opportunities for improving maternal health out to the public. We know many in the audience today are healthcare partners, and also many are from business, philanthropic, and the general public. Our goal today is to connect the dots on daily health habits and the opportunities each of you have to play a role in improving maternal health for our families and communities. You'll see much of this opportunity is in cardiovascular disease and hypertension control. Without further ado, I'm going to move to introducing our three esteemed experts and panelists. First up is Dr. Sherry Onyego. She's a board certified family physician with over 15 years of clinical experience in managing and treating clinical diseases. And it is, as it relates to individual care as well as population health. She previously served as the Director for Nutrition and Chronic Disease Prevention in the Nutrition and Chronic Disease Division at Harris County Public Health, which is a nationally accredited county public health agency for the nation's third largest county with over 4.7 million people. Dr. Onyego, the stage is yours.
Thank you so much, Heidi, and thank you, American Heart Association, for really bringing forth this very important discussion today. So for my time on this panel, for this brief presentation, I really just wanted to give you an overview of the Texas Maternal Mortality and Morbidity Review Committee, some of the key findings and the data that goes along with those findings, as well as some of the recommendations that the committee has put forth. So first, I'll just, if you go to the next slide, I'll just talk to you briefly about the overview of the review committee. In the Texas legislative session in 2013, the Maternal Mortality and Morbidity Task Force was created. In 2019, the task force name was changed to the existing name now, which is the Texas Maternal Mortality and Morbidity Review Committee, and that really was in alignment after the Federal Prevention Maternal Deaths Acts of 2018. And our review committee is quite diverse. We have really a wealth of expertise from review committee members from really across the entire state with very diverse expertise. From maternal fetal medicine, from obstetrics and gynecology and various other areas, case management, social work, nursing. I serve on the committee as a family physician to bring that perspective. Later in the discussion today, you'll hear from our chair, Dr. Oye. And so we have about 17 members in the review committee. And we really work to study and review cases of pregnancy-related deaths and look at trends in those maternal and maternity mortality and morbidity outcomes. We also determine the feasibility of the review committee to study those cases. And finally, we make recommendations to really help reduce the incidence of pregnancy-related deaths across the state. Next slide. And so one thing that I'll drop it in the chat as well, but there's a link that I'll include in the chat box that really takes you to a comprehensive look at our review committee joint recommendations or our joint biannual report. And that really is an opportunity for the community to see our broad, comprehensive recommendations, as well as the key findings that really looks at the pregnancy-related deaths, the trends, as well as best practices across the states with other programs and services. So I'll drop that link in the chat, but I wanted to start off again by just really, for the time that I have here, to just walk through some of those key findings and then just end this talk with a few of the recommendations from the committee. But first, we know that there's a great discrepancy or disparity in the mortality, in maternal mortality specifically. And specifically for the purposes of this graph, I really just wanted to point out that non-Hispanic Black women really are quite disproportionate in those disparities, with 31% of the deaths being amongst non-Hispanic Black women, and they only make up 11% of the live births in our state. And again, this data is just going to really focus on our 2013 cohort of pregnancy-related deaths. So as I go on throughout the next few slides, you'll see that that's going to be the cohort that we'll highlight for the data. Next slide, please. And when we look at timing of maternal death, it's really important to note that of the 54 pregnancy-related deaths from the 2013 cohort, 29% of those deaths occurred while women were pregnant. 40% of those deaths occurred within 42 days of the end of the pregnancy, and 31% of those deaths unfortunately occurred within 43 days to 1 year. And when you look at the bar graph to the right, it really shows the timing of death and that it's distributed throughout the course of the pregnancies for the leading causes, underlying causes of death, whether that's cardiovascular, preeclampsia, eclampsia, infection, obstetric, and hemorrhage. So could you move to the next slide? And when we talk a little bit about preventability, that's really an important thing that we as a committee really focus on. We look to see if there was at least some chance that a death could be averted by one or more reasonable changes, whether that's a change in the circumstance of the patient, the provider, the facility, the system, or the community. And oftentimes the committee, we look at categories of the timing, of the prevention, and we look to see if there was no chance, some chance, or a good chance that this death could have been prevented. And what we found is that 89% of the deaths that were reviewed in the 2013 cohort, they were preventable. And when we look at the bar graph to the right, you can see that, again, preventability varies across the multiple different causes of death. And one thing that we can also point out, especially for the purposes of this talk today, is that all of the reviewed pregnancy-related deaths were due to hypertensive disorders were believed to be preventable. Next slide, please. And if we get next slide, please. I'm sorry. And if we talk a little bit more about the disparities in hypertension, what we know is that the rates of hypertension, the rates of delivery hospitalizations involving those with a hypertension-related disorder, that those rates have increased from 2011 to 2018, respectively, across all racial and ethnic groups, but it's certainly highest amongst non-Hispanic Black mothers. And when you look at it across the entire state, it's quite dispersed throughout the entire state, but certainly more concentrated in the central portion of Texas as well as the southeastern portion of Texas. Next slide, please. And finally, I'll just end with a few of the recommendations. And like I said, I will drop the link for the biannual report, and it will be much more comprehensive in terms of the full recommendations and the full findings of the committee. But a few of the recommendations that I wanted to leave you with that really tied into the topic that we are talking about today includes a few, such as increasing access to comprehensive health services. And those are at critical time points during pregnancy, the year after pregnancy, throughout the preconception, as well as the interpregnancy periods. And really that's to ensure that there's continuity of care, improvement of lifelong health of women. The other recommendation that I wanted to point out is engagement, and specifically engagement of Black communities and applying a health equity framework to those engagement opportunities and programs and services. And the other recommendation that really is important to point out is that it's so important to foster those community environments and leverage those important programs and services that also help with the women of childbearing to be able to achieve their full health potential. And finally, the implementation of statewide maternal health and safety initiatives to really reduce maternal mortality and morbidity. And so I know that we'll be able to dive in a little bit more in depth with these recommendations as the panel goes on, but I'll go ahead and turn over my time to the next panelist. Thank you so much.
Thank you so much, Dr. Onyego. I love the conclusion with the recommendations and calls to action there. Really powerful opportunities, clearly. So let's move to our next panelist, Dr. Lisa Ollier, who is a professor of obstetrics and gynecology with Baylor College of Medicine here in Houston and the chief medical officer at the Texas Children's Health Plan. Dr. Ollier completed roles as president and CEO of the American College of Obstetrics and Gynecologists, where her initiatives focused on reducing maternal mortality, including updating ACOG's guidance on pregnancy and heart disease. Throughout her career, she has been dedicated to reducing health disparities and improving women's health by advancing women's health policies. Thank you so much for being here today, Dr. Ollier. You've got the floor.
Thank you so much, Heidi. I am incredibly excited to be a part of this panel today. Thank you so much to the American Heart Association for bringing us all together today, especially during Black Maternal Health Week. It's incredibly important that we're here, that we're talking about health disparities and the solutions that we can put into place. Dr. Onyego, thank you for your really great summary of the findings of the Texas Maternal Mortality and Morbidity Review Committee. As you know, cardiovascular disease, cardiovascular conditions, and cardiomyopathy account for approximately 1 in 4 or 25% of pregnancy-related deaths. This is incredibly important. And hypertension is another important contributor. Next slide. There are so many important aspects to improve women's health in Texas. The social drivers or social determinants of health are incredibly important: healthcare coverage, access to care, and then chronic medical conditions. The review committee identified that chronic medical conditions do contribute importantly to rates of maternal mortality and morbidity in Texas. And I wanted to talk about 3 of those conditions today: obesity, hypertension, and diabetes. Next slide. Many of you recognize that these conditions are part of the traditional risk factors for cardiovascular disease. So this is no surprise that they are important contributors to maternal health across our state. Other traditional risk factors are displayed here. And in the second part of the information that I'll present, I'm going to give you some non-traditional risk factors for cardiovascular disease that are very important for us to know. Next slide. On this slide, you can see that rates of obesity are significantly increasing. If we look at the state of Texas, starting just over 22% back in 2010, and here we are in 2019 with rates that approximate 30% of women, you can also see that there are disparities in the prevalence of obesity across populations, with non-Hispanic Black women having the highest prevalence of obesity. Next slide. The findings are very similar for our other health conditions. If we look at hypertension on the previous slide. Excellent. You can again see an increasing prevalence of hypertension for Texas women, increasing for all race and ethnicity groups, but once again, the highest prevalence for non-Hispanic Black women. Next slide. Looking at diabetes, we can see, once again, rates are increasing. In this case, we have the highest rates for women whose race and ethnicity was classified as other, followed by rates of diabetes increasing among Hispanic women. But it's incredibly important for us to recognize we've talked about 3 very important risk factors for cardiovascular disease: obesity, hypertension, and diabetes, and all 3 are increasing for all women across the state of Texas. Next slide. I want to talk to you about the impact of pregnancy complications. Our wonderful introduction outlined that pregnancy can be thought of as sort of a stress test for future outcomes, and that's true. Pregnancy complications like high blood pressure during pregnancy, preeclampsia, eclampsia, what people call pregnancy-induced hypertension, all of those complications are associated with a higher risk of cardiovascular disease later in life. And this is incredibly important for us to know, and it's incredibly important for us to raise awareness. These pregnancy complications, once again, high blood pressure problems of pregnancy, gestational diabetes, preterm birth, or a baby that is small for the gestational age at which it's born. When you have these factors in combination, the long-term risk of cardiovascular disease increases even more. Next slide. So what do we do about it? The role of the primary care provider is incredibly important, and those visits that women have with their OBGYN or other primary care provider are incredibly important opportunities for providers to identify and counsel women. We need to be able to talk about these past pregnancy complications and then counsel women about healthy lifestyle and minimizing their health risks. For some women who have significantly increased risk, collaboration with an internist or a cardiologist is also very important. Next slide. But we need to be sure that women can get that care, that women get the care they need. So one of the task force recommendations that Dr. Onyego has already mentioned is increasing access to comprehensive health services during pregnancy and the year after pregnancy, and then throughout the preconception and interconception periods. This access to healthcare is incredibly important. And I think we'll have an opportunity to elaborate a little bit more on opportunities like this later in our discussions. That's my last slide, and I'm happy to hand it back to Heidi for the introduction of our next panelist.
Thank you, Dr. Ollier. Again, great recommendations, and looking forward to diving into this a little bit more in our panel shortly. Next, I will introduce Ms. Julie Stagg. She is with the Healthy Texas Mother and Babies Branch, a nurse manager and the Texas AIM Program Director at the Texas Department of State Health Services. Welcome, Julie. Ms. Stagg has worked for over 25 years to promote maternal and child health in mental health and hospital and community-based as well as public health settings. She is proud to have served about 15 of those years as the maternal and child health nurse with dishes. Along with her staff, she provides expertise and coordination for a suite of policies, programs, and initiatives to promote maternal and infant health strategies across the state of Texas, which includes the Texas AIM Initiative. Welcome, Julie.
Thank you so much, Heidi, and thank you, American Heart Association, and to my esteemed panelists. It's such an honor to be here with y'all today. I'm going to talk briefly about some of our maternal health and safety initiatives that we have at Texas Department of State Health Services, and really honing in on one of those recommendations that we heard about, which is around implementing statewide maternal health and safety initiatives to reduce preventable maternal mortality and morbidity. Next slide. So I wanted to reiterate the importance of referencing the Texas Maternal Mortality and Morbidity Review Committee and DSHS joint biennial report, which is available from the Department of State Health Services website. And I believe a link will be placed in your chat to read the findings and recommendations. This report is published biannually and was released in September of 2020. Also recently released is another legislative report, which is around our maternal health and safety initiatives. And so more details about some of the topics that I will discuss briefly are available there at the same website on our legislative reports page. And that was released in December of 2020. Next slide. I wanted to start by providing an overview or framework that we use at Texas Department of State Health Services to organize our maternal health and safety initiatives, and so that they are addressing levels of prevention. At Department of State Health Services, we implement public health and population-based strategies to improve health and safety of Texans. And within the Healthy Texas Mothers and Babies branch that I supervise, our mission is to improve maternal and infant health and safety by advancing quality, equity, and evidence-based prevention to all Texas mothers and babies. And we organize our maternal and infant health initiatives in this framework that you see here. And it includes addressing or having programming and efforts across a spectrum, including individual and public awareness and knowledge. And so our maternal health and safety campaign, which is currently in development, is a component of this. Professional education, such as grand rounds, online provider education, and annual summits, including the Texas Collaborative for Healthy Mothers and Babies annual summit. And then community empowerment, including through activities of our Healthy Texas Mothers and Babies community coalitions across the state. Community improvement to make environments promotive of health and healthy lifestyle choices, and to reduce barriers to health. And this includes things like our Texas Mother Friendly Worksite program, that's a policy-based recognition program for employers. And finally, I wanted to draw your attention to the Perinatal Quality Improvement Network, which is kind of a synthesis of these efforts at a higher level. So really about changing systems. And within this network, you'll see here the Maternal Mortality and Morbidity Review Committee as a component of the improvement cycle. And for maternal health efforts, that the findings and recommendations of that are published in that biennial report really do drive our maternal health and safety initiatives in this category. And then also many of the other things that I've already mentioned are direct results of the recommendations of the review committee. And so within this area is our Texas AIM initiative and Texas Collaborative for Healthy Mothers and Babies, which I'll talk a little bit more about in just a minute. Next slide. So the Texas AIM initiative is our state platform for delivering a national effort. In Texas, we are proud to be a part of the National Alliance for Innovation on Maternal Health implementation arm. States all across the country are participating in providing programming, technical assistance, and support to hospitals in their states to support their efforts in making healthcare safer for every mother. And the Alliance for Innovation on Maternal Health, or AIM, is administered by ACOG, and they have endorsed maternal safety bundles that have practice and policy changes for implementation. And so when those components are implemented together, those evidence-based strategies can result in a reduced rate of severe maternal morbidity in those areas, as well as all kinds of other benefits. But ultimately, that's our objective. Each one of these bundles is organized in the 4 R's. So ensuring that a hospital is, or in a healthcare setting, is ready for an obstetric emergency before it happens. And so that's things like having policies and just basic structures in place to be able to respond quickly and efficiently, because everything is lined up. Your staff are educated, your equipment is in place, your policies support effective action. Recognition and prevention is the next R, and this is being able to see the early warning signs for obstetric emergencies and being able to prevent them from getting worse, but then also being prepared to act. And so that third R is response, and having a standardized approach to ameliorate the issue at hand and treat it according to guidelines to improve outcomes. And then finally, reporting and systems learning is about having structures in place and a culture of safety in an institution to be able to continue to learn from and improve care. And so the bundles that we are implementing through Texas AIM, we started with obstetric hemorrhage and through a learning collaborative, and wound that down in December, and have just started to launch severe hypertension and pregnancy. And this includes, the focus of it is the care provided in the hospital, but clearly with hypertension, there is quite a bit of need for coordination beyond the labor and delivery unit, or even the women's services. So engaging emergency departments, and then also smooth transitions of care for and with a focus on postpartum follow-up and those kinds of things. So there's a lot of opportunities beyond just that core focus of the hospital for partners to support this work. And then finally, we'll be launching an obstetric care for women with opioid use disorder initiative this summer. Next slide. So the great news about Texas AIM is we have had an overwhelming amount of uptake from hospitals across the state. And that's where the work happens. There's amazing participation and buy-in and hard work happening to make healthcare safer for women. These are data from our obstetric hemorrhage learning collaborative, because we're still recruiting for hypertension. We're in the final stages of that, but at the peak of our recruitment, we had 98% of all hospitals participating, which accounted for over 378,000 births per year. In Texas, we're a very large state, as you all know. That's 99% of our births here in the state, which is equivalent to 10% of the births in the nation. And so when we make improvements in Texas at this scale, we have an opportunity to also improve health at a national level, improve outcomes. Because our state is so large, we have in-person learning sessions once we're able to get together in person again in each of 5 cohorts. Next slide. And we use the Institute for Healthcare Improvement Breakthrough Series model for collaborative learning to work together with improvement teams in each hospital across the state. We are very excited and fortunate to have Eleni Sigas from the Preeclampsia Foundation joining us as our patient representative as the Texas AIM patient representative for our planning team, and we'll have a real focus on including women's voices, mothers' voices in the teams, the improvement teams, as well as in our learning collaborative. so that we're addressing one of the key strategies for improving health, which is involving communities impacted by these health outcomes. Next slide. I also wanted to make the connection that DSHS also funds through our Healthy Texas Mothers and Babies initiatives, our state perinatal quality collaborative, the Texas Collaborative for Healthy Mothers and Babies. And the State Perinatal Quality Collaborative has a mission to advance healthcare quality and patient safety for all Texas mothers and babies through the collaboration of health and community stakeholders. And there are, the way the collaborative is organized, there is an executive committee, and there's neonatal and obstetric and community health committees that develop quality improvement initiatives for implementation. There's also a data work group, and there's engagement in this, in the TCHMB of the regional advisory councils, or the regional or associations of hospitals that come together to work on quality improvement initiatives as well. And so TCHMB is a great platform for becoming involved in quality improvement efforts. And the obstetrics committee will also be supporting at a local and regional level the work around hypertension as we roll out the AIM bundle statewide. And I believe that's my last slide. So thank you very much, and I'll turn it back to Heidi. Heidi, you're on mute.
Thank you. Thank you, Julie. And thank you for that overview of everything that the state is doing to improve maternal health. What an opportunity to have 10% of the nation's births in our state and to drive towards improving those outcomes in a systemic way. Really appreciate that. At this time, I'd ask each of our panelists to rejoin me on this virtual stage, and we'll transition into more of a discussion on the great information each of you have shared with us, kind of framing up what's happening in this space, and now focusing on a bit more of those opportunities and recommendations. And we know that maternal health and maternal mortality crises are impacting mothers inequitably across Texas. What do y'all see are the key opportunities for improving health of all mothers and then reducing those pregnancy-associated morbidity and mortality rates equitably? I'll pause there, and perhaps if you would start, Dr. Ollier.
Thank you so much, Heidi. I think when we look at the data, we know that the leading cause for maternal mortality in our state is cardiovascular conditions. With the addition of cardiomyopathy, that accounts for nearly 1 in 4 of all of our maternal deaths. So we know cardiovascular conditions is an area that we need to really be focused on. Hypertension, again, another important contributor. So I think the key chronic conditions, if you will, would be obesity and hypertension, again, both disproportionately higher in our African American communities. So I think those are areas that are incredibly important for focus. And I think that focus needs to be not just on healthcare, but we need to be sure that we're moving upstream, we're catching that access to great healthcare, and then catching those social drivers of healthcare outcomes as well.
Yes, thank you. Dr. Onyega, let's go to you next, and perhaps if we can lean a little bit more on what's happening here in Harris County and your experience there and some of the inequities and the opportunities.
Yeah, thank you, Heidi, and thank you, Dr. Ollier, really kicking us off. And really, I certainly agree with everything that you've said in terms of where our data is, in terms of the cardiovascular implications, and certainly those chronic conditions. Those are top chronic conditions also that we are seeing across the entire county. Having had the privilege of really looking at chronic disease prevention services and programs for the county for a number of years, obesity, diabetes, and cardiovascular disease is something that really impacts our entire community here in Harris County. And certainly, I think that one of the things that we have continuously really tried to drive in terms of when we talk about those upstream solutions is really increasing opportunities for engagement, for education, to really deploy prevention-related services, if you will, across the board. And really, I would have to completely agree with what you said, Dr. Oye, really changing the narrative from the traditional four walls of the healthcare structure to really looking at how we can take those prevention-related programs and services to the community, whether that's on, mobile platforms, whether that's utilizing existing community-based programs, whether that's WIC programs and services, because you want to reach people where they're already accessing multiple different programs and services. We also certainly want to lean in on our medical home partners, like our federally qualified health centers, because they play an important role too. As we mentioned earlier in the discussion, we're not just talking about helping to improve outcomes of women during their pregnancy. We want to reach them at multiple points of their healthcare journey. And so certainly that pre-planning time period, postpartum, really wanting to really ensure that they get ushered into a healthy pregnancy and then have a healthy supporting structure after that. So I think that those are some great opportunities to really look at education, prevention, interventions, whether that's on our community-based programs and services that are truly outside of those traditional four walls of the healthcare system.
Thank you. I love the spectrum, and we're going to zoom back out to the state. And speaking of spectrums, that slide that you had, Julie, where you organized, or the state has organized the many different interventions across kind of those opportunity channels. I love the way that that was framed. Could you highlight some of those pieces and opportunities for us, and thinking too of not only at the systems level, but then that the individuals level, knowing we have some individuals in the conversation here today.
And just so y'all are aware, my son just started jazz band, so you'll hear a steady rhythm in the background. Think of it as a heartbeat. Yeah, so starting with the individual, I wanted to just reiterate in terms of increasing equity in outcomes for women, for mothers. It's the importance of engaging the communities in the design of the programs that we're planning for them, so that they are going to meet the needs of that community. So I think that that is a really critical component. That is also one of the recommendations of the review committee. So I'm going to probably be constantly turning back to that as a great source for inspiration for these things. And, along the spectrum, it's having information around having information for individuals. So that is things like being aware of urgent warning signs, healthy lifestyle choices, to Dr. Onyego's point of having women be healthy as they're coming into pregnancy. But then along with those, that information and education at the individual level, and for a women's support network, having those same messages amplified at other points, whether that's through public education and awareness campaigns, but also at the points of care where she might be touching, so that those are echoed and reinforced. And moving along our spectrum of prevention, when people have identified shared goals around health improvement, having them come together and figuring out how they can work together to maximize their impact, leverage their strengths, and not recreate the wheel, but amplify the efforts that they're working towards. In terms of healthcare, I think, again, kind of back to that individual engagement, fostering a culture of shared decision making in healthcare so that the patient is a partner in her care, and for health and healthcare organizations becoming familiar with and integrating national standards for culturally and linguistically appropriate services, including which information about that is available from the Office of Minority Health, so that those standards are being implemented consistently across settings and to increase health equity.
Thank you, Julie. I loved the theme across what you talked about the role and the leadership of the individuals in their health journey, how powerful and how important for those of us in the health promotion space to be cultivating that always in the work we're doing. Dr. Ollier, would you speak a little bit more on your recommendations to women and them taking control of their own health outcomes and improving their own health outcomes?
Absolutely. I think it really starts with women feeling comfortable speaking up and speaking out. And at the very same time, our healthcare community needs to join them and welcome them and really genuinely listen to women. We need to listen to what they're telling us. So the foundation, I think, of engaging women really, as we've all said, starts with women. Centering all of the programs on the women that we want to serve and really ensuring that they're a part of deciding what the programs become. I think there are a lot of really wonderful opportunities to ensure that women are engaged in these healthcare processes, and there's some great examples. When we're able to use tools like self-monitoring of blood pressure, that really engages women and that draws them in to be participants in their care. And as the care providers, and we can use text message reminders, for example, or other things that really help draw them in. Other techniques to really draw women into participating in their healthcare include things like support for telehealth. Again, drawing them in, meeting women where they are so that we can work with them in any particular type of situation. And then finally, I think digital networks. After this last year in the, living in the midst of a pandemic, we've done so many things like this where we're not together, but we're together and we're sharing and we're talking and interacting. And I think forums like this and other digital networks can be really important in ensuring that we have the very women we want to reach actively engaged in their care.
I love that. How do we connect more people to these important messages? Dr. Onyego, what would you add for your recommendations to women in taking better control of their health and improving their health outcomes?
Yeah, I think certainly I would agree with the recommendations and certainly the comments that Dr. Ollier has already so very, very eloquently described. I think that one of the things that we also want to maybe recognize too is the importance that women can have with engagement to community-based organizations that are really looking to recognize the impact that they can play on improving maternal health, and certainly those community-based organizations that that really support a lot of efforts such as 211, that's basically a centralized referral-based program where women could certainly access one centralized repository of community-based opportunities and resources that they may need. Just making it easier for women to connect instead of going to multiple different outlets. And so certainly advocating to support community-based organizations that really support those initiatives. And also other things such as, like I think we talked about a little bit earlier, the importance of other community-based organizations that support a medical home-based model where women that are already engaged in their health care can really receive that comprehensive health care in a setting with primary care providers, behavioral health providers, and other healthcare professionals that they already know and that they already trust, so that those relationships are already built and that foundation is already there, and that we continue to support medical home-based models because of the very important and vital role that they play. And I think that in terms of certainly I'd be remiss if I didn't talk a little bit about some of the public health work. But we, obviously there's so much to say about the environments and the structures that we all live in. And certainly providing safe community-based structures for women to have walkable communities that they can go and do exercise and tap into the community that's around them to be able to help them have healthier lifestyles. So I think that, and certainly that also plays into where women can have and families can also have healthy access to foods. And so all of those things that really support that full scope lifestyle interventions and lifestyle changes.
Thank you. Thank you for raising it up the different levels, because we've all got a role to play in this. And when you look at the opportunities, they're so similar to many of the other chronic conditions that we're focused on, and helping women see the connection between, their health throughout their life and how that impacts their maternal health and their baby's health, also moving forward. Julie, when you look at what the Department of State Health Services is doing, like the TCHMB conference and the Texas AIM bundle, and those systems changes opportunities of what you're doing, like looking at that from the lens of businesses and philanthropists and community leaders, taking what Dr. Onyego was just saying to the next level, what do you see as those opportunities for organizations who maybe have broad networks but aren't as necessarily in the weeds or in the healthcare setting? What do you see as their opportunities for improving maternal health outcomes?
Yeah, that's a great question. And first, I would say, I think just part of that is reading the maternal mortality report and thinking about what role your organization could have in supporting implementation of the recommendations as kind of a first step. But another area that I always think about when I'm working with organizations is to think about first, how are things at home? And as somebody who implements a program that works with employers to make environments promotive of health for postpartum women with a mother-friendly worksite program, I think that can apply really well for maternal health in general, to look at as the first place to start thinking about how does your organization support maternal health now, and where are there opportunities for improving that? How do your policies impact maternal health, things like leave policies and the benefits packages that you have? What kind of wellness programs do you have that could support maternal health? For, you can incorporate men into those as well, and supportive of partners through that. So there's opportunities there. And to your point about a life course approach, the U.S. Department of Health and Human Services released an action plan to improve maternal health in the United States, and then also the Surgeon General's call to action to improve maternal health. which incorporates a life course approach through improvements in individual, community, and healthcare actions. And there are recommendations that apply to every body that we can all do, but then there's also specific sector recommendations. And that includes things like addressing mental and physical health, supporting healthy behaviors throughout the life course, like healthy eating, smoking cessation, physical activity, and breastfeeding, addressing factors with overall health and well-being, and paying attention to those social determinants of health, addressing healthcare disparities and chronic conditions and diseases, as well as learning about early warning signs and looking for opportunities to promote awareness about those for women who are pregnant or postpartum.
I love that robust set of opportunities. If we have the link to that document, I think that would be a great resource for the audience. Dr. Olea, do you have additions and thoughts or strategies for businesses, philanthropists, and those who aren't necessarily in the healthcare space?
I would really like to focus on the social drivers aspect and partnerships that we can establish there. There are so many wonderful opportunities for our community-based organizations to work with either healthcare providers, whether it's federally qualified health centers, private physician practices, or health insurance plans, right? We all have the same goal: better outcomes for women, better outcomes for our communities. And there are so many different opportunities to partner. Please, if you lead a CBO out there, please reach out to your medical community. We want to work with you. We want to partner with you because it gives us the opportunity to meet women where they are, to provide relevant services in their community with trusted partners. So I think that's a super opportunity.
Thank you. And I'm seeing we have a question in the chat, which let's raise that up. How does maternal mortality and morbidity in Texas compare with other states? Perhaps we can start with you, Julie.
Yeah, and actually we're not really in a position to be able to compare that right now. There is part of the work across states in having maternal mortality and morbidity review is because we have such inaccurate ways of understanding what's happening around maternal mortality and morbidity at a federal level. And so the way that we're able to measure maternal mortality differs from state to state. So in our report, you'll see a maternal mortality ratio that's based on our methods here, but that method is not used by other states. And there is work at the federal level to improve those data quality to be able to make better comparisons. Dr. Olea.
So important to be able to tell a story, to be able to measure it consistently. Well, we just have a couple of minutes, so I just want to thank each of you for taking your time to share your expertise and the great work that you guys are doing in this space. And I hope everybody is going to take something away from this. I will pass it to Larissa to close us out. Thank you all.
Thank you so much to Heidi McPherson, to all of our expert speakers. I cannot tell you how much I enjoyed this panel today. I have some catch-up reading afterwards, and I hope you all will look at the chat box to see some of the wonderful resources that we've been able to upload into the chat box, and some great links there. As Heidi mentioned, my name is Larissa Jacobs. I'm the VP of Health Strategies for the American Heart Association in Greater Houston Gulf Coast. And I just want to say we must take action together to improve maternal survival rates in Texas. We need to really take a look at the problem of hypertension in these populations and what can we do together collectively with our community-based organization partners, our clinical partners, most importantly, with all of the stakeholders that really can help us to understand the problem deeply. Again, I really appreciate all of you logging in and being here. Have a wonderful day. Websites are in the chat box. If you'd like more information about AHA, visit us at www.heart.org. And thank you again. Have a great rest of your day.